Good afternoon. Welcome, everybody, to today's Tuesday topic, Propofol and PRIS, not just rhabdomyolysis. So really, really important since we love Propofol. We use it everywhere. We use it for procedural sedation, for continuous sedation. We use it in the emergency department, the PACU, and the ICU. We use it in so many different areas, but there are some really important concepts for us to think about when we're administering Propofol. Thank goodness that in general, the safety profile is excellent, but there are those times when you have patients who might present with some abnormalities that you should quickly recognize may signify a failure of metabolism at the cellular level that's been induced by their Propofol infusion. So I'm going to start off with this patient, this lovely case. This is a 72-year-old male who has a past medical history of hypertension, stroke, end-stage renal disease. He lives on hemodialysis, has type 2 diabetes, and he has known, as most chronic kidney disease patients do, known anemia. And he comes to the ED presenting with a fever and a cough for about the past 3 days. Physical examination is positive for crackles in the bilateral lung fields. This was really during the time of COVID. He is diagnosed as being COVID positive. He has bilateral interstitial infiltrates, and he gets admitted to the MICU because of his severe hypoxemia. He's intubated, started on propofol and fentanyl for sedation and analgesia. He also receives multiple vasopressors due to septic hypotension. So norepinephrine, vasopressin, epinephrine, titrated up. And as he goes over the next day or two, he actually projects multi-organ dysfunction. Now, the fact that he's getting CRRT is only because he's unstable. Otherwise, even in the time of COVID, it would have been best for him to receive hemodialysis because that's what he normally and typically receives. But because he became unstable, we actually chose to put him on CRRT. On day 2 on CRT, sorry, the date isn't there. Day 2 on CRT, the alarm started going off, both with extreme positive pressure on the return line, that's the blue line, and extreme negative pressure on the access side, that's the red line. So if you're using whatever device you use, just remember access is what's removing the blood from the patient. Return is what's returning the blood back. Even though they're colored red and blue, they are both venous. And what's actually happening is something very, very significant. The nurse actually notified me that the filter had something that looked like chocolate milk in it. It was kind of light beige. The picture wasn't that great, but light beige in that filter. And that also had a chocolate milk appearance in the tubing as well. Now, this is something familiar to many people who have used Propofol for years, and especially when you're using higher dose Propofol and you draw a lab and the lab draw is very white or has deposition of lipids in the lab draw. This is all lipid emulsification. And so very smartly, the decision was made to quickly draw a serum triglyceride level, and that was significantly elevated, knowing that normal range typically would be around 149. That's the average mean. This patient's triglyceride level is 930. Now you're thinking, well, lots of people have hypertriglycerides. That shouldn't be such a big problem. But this is a rapid introduction of an elevated triglyceride level. And in this case, the occlusion here occurred both in the filter and in the catheter. So we had catheter problems and filter problems associated with the high degree. And it wasn't extraordinarily high. It was a normal level, 50 to 60 milligrams of propofol. So it wasn't extraordinarily high, but for this patient, because of his comorbidity and most likely his inability to clear or break down the propofol, he actually presented with this high triglyceride level. Now, it is important to remember about propofol, how much we adore it, and we should. It's a really great agent. It is the most commonly used IV anesthetic. And the reason it's so great is people are unconscious really quickly. If you've ever received it, you know that you're gone in 45 seconds. And And just a procedural dose lasts about 15 minutes. That 15 minutes generally is enough time to do a short procedure, and it will dissipate pretty quickly. But you can receive multiple doses and get a longer period of time. It's also antiemetic. It doesn't irritate your airways. It's very well suited, of course, for procedural sedation. Very well suited for same-day surgeries. Not so great in that population because it can cause some pain during injection and because it can drop your blood pressure. Now, when we talk about it in the ICU setting or in the emergency setting, outside of procedural sedation, we like it because it's quick on, quick off. We maintain it for periods of time. We think that it has a lot of differences from benzodiazepines, but after about 24 hours, the kinds of initiation of delirium are going to be very similar with propofol as they are with benzodiazepines. So we don't want to fool ourselves that propofol is significantly better than benzos. It is not significantly better than benzos, except the withdrawal profile will be much simpler than with the benzodiazepine. Now, really good and important things to say is that it is a hypnotic agent, right? So remember what that means. It means that it really does promote kind of forgiveness and failure to remember what's occurred, which can be very, very beneficial. It's also important to remember that propofol does not have any analgesic properties. So if we are controlling pain, we must add a secondary agent. Typically, the agent we like to use will be fentanyl. Fentanyl has sedation and analgesia, but don't let anybody say I'm using fentanyl for sedation. Really, fentanyl's for analgesia. Propofol is for sedation and anti-anxiety, and also to promote amnesia. Now, what's really important about propofol is that it really affects the membrane around the cell. That's a lipid membrane, and that affects the way sodium moves back and forth across the cellular wall. And that's quite important. We're going to look at what happens, very, very generically look at what happens when we're administering propofol, what happens to the cell membrane, and what actually can happen to the channels, particularly those channels, sodium, potassium, and calcium channels that are necessary for sustained and well-managed cardiac depolarization. Again, very rapid onset, very rapid offset, and typically we like about 1 milligram per kilogram IV bolus and 0.5 milligrams per kilograms Q 45 to 60 seconds. So that's going to be your continuous drip. Now, my friends, I want to make sure you know this is a weight-based dose. And that's because if you just use standard dosing, you may overdose somebody who is smaller and underdose somebody who is larger. And that's why it's a weight-based dosing profile. Again, rapid on, rapid off, easy to titrate, antiemetic, bronchodilator, gorgeous, gorgeous. But remember, no analgesia. So unlike some other agents like ketamine, so some of you probably would talk about ketofol, which is ketamine and propofol together. It is also really important to remember that it has a very significant and profound cardiodepressant effect. Now, most of us don't talk about that or think about it when we're administering propofol, but because of the change in the lipid shell of the cell, you can actually see some significant depression in cardiopulmonary function, most particularly cardiac function. It can depress cardiac contractility, can also alter the receptor site response to catecholamines, things like a beta stimulant, an alpha stimulant. So really, really important for us to remember that as we utilize propofol, just like almost like it's water, and we adore it. It's a really important agent in our profile. But what I want you to note is this. I put this little memory up here just to remind us that propofol actually generates reactive oxygen species. So what that means, I'm a simple girl. I want to make it really simple. When we talk about reactive oxygen species, these are unstable byproducts of oxygen metabolism. One of them would be something similar to hydrogen peroxide. So OH, one oxygen, one hydrogen, hydrogen peroxide. These are unstable and they can cause some cellular dysfunction. This really is important. The other aspect of propofol, because of its lipid base, is that that lipid base stimulates a switch at the cell for metabolism, and it switches at the cell to glycolysis. And if the patient doesn't have adequate glucose stores, typically carbohydrate infusion, that means D5, D10, maybe D50, tube feeding. If that patient doesn't have an adequate carbohydrate reservoir, this will actually promote damaging of the cardiac muscle. It also can damage the liver mitochondria, but for us today, we're really focusing on the cardiac muscle. Now, that's a really important concept. I don't think any of us really think about propofol as being a cardiac depressant. We worry that our patient's blood pressure might drop. We worry that the patient's heart rate may slow. But beyond that, it actually depresses cardiac contractility. So let's just take a quick look at the effect of propofol on the organs. So first of all, for cardiovascular, certainly we can appreciate that it promotes vascular relaxation. So the resistance of the vessel drops and hypotension can be very pronounced. One of the comparative analyses from an anesthetic point of view is a comparison of propofol to thiopental. And it's very, very important just for us as bedside nurses to recognize that as we introduce propofol to our patient, we may see significant hypotension. Nobody here is surprised by that. Every time you're giving propofol, when you give a bolus, you can probably recall many times where patients drop their blood pressure. Now, typically, what's also really important is to remember that when vascular tone is enhanced and the vessels are decreased, and the vessels dilate, your typical expectation is that the heart rate will go up. But with propofol, you typically will not see reflex tachycardia. You will see that there won't be much change in the heart rate, or the patient may even be bradycardic. Now, I always warn, bradycardia plus hypotension, that's disastrous. Typically, when I say bradycardia and hypotension in a newly intubated patient, I say consider pneumothoraces. That may be the problem. But now we must also consider this is a response to the propofol, and you may have to turn the propofol down to off if your patient's hypotension, bradycardia don't actually restore very quickly. In terms of the pulmonary organ effects, one thing we all can appreciate is that propofol causes very significant and profound respiratory depression. That's why, of course, we don't want to have patients on propofol as we are evaluating them for readiness to wean. And we do want to remember that after patients have been on 24 to 48 hours of propofol, they're going to have some secondary products that will still cause some respiratory depression. So we can't always expect that rapid on and rapid off is always going to occur if we've had patients on for any period of time. Again, greater than 48 hours is the typical rule of thumb. Now, the other issue that's really important here is that with suppresses our respiratory effect, and it does that primarily by inhibiting the drive to breathe based on low oxygen and the drive to breathe based on high CO2. So those are two things that can happen with our propofol. They happen all the time. This is why, of course, a lot of our folks say, well, it's the Michael Jackson drug. Well, yeah, Michael Jackson overdosed himself with propofol and he wasn't intubated. If you're intubated, we're not so worried about it because we can manage you with our ventilator and through the ET tube. But as we're coming off of propofol and considering readiness to wean, we want to be sure that we have as much clearance of propofol as possible before we look at readiness to wean the patient. Okay, now it also really significantly decreases the gag reflex, which makes it ideal for intubation or for the placement of an LMA, because that's going to actually reduce that reflex without requiring paralytics for me to intubate you safely and comfortably. Okay. And again, very safe because it causes some bronchodilation, very safe for asthmatic patients, which is absolutely a plus. Now, the other thing that propofol does is it decreases intracranial pressure. Now, I want to really talk about some caution here, And that is what we want to remember, that the components of intracranial pressure are blood, controlled brain, and controlled cerebral spinal fluid. But when we have brain injury, we may need a higher level of blood flow. And because propofol promotes vasodilation, the cerebral blood flow may go down. Now, metabolic rate will go down. Other secondary effects will occur with propofol. But I want to remind you that in increased intracranial pressure, your goal is not to reduce cerebral blood flow. Your goal is to reduce cerebral spinal fluid, the mass lesion, the free blood, and the metabolic rate. So just balancing that when we talk about cerebral effects of propofol, very, very important. Okay, again, it has antiemetic properties and also has a little bit controversial, sorry to say, anticonvulsant properties. There's a recent study in a group of about 140 pediatric patients that actually correlated to utilization of propofol with increasing seizure activity. But it's a very small study and not very well controlled. Just want to make sure we are up to date on the evidence and the literature when we're talking about our patients and how we're going to utilize these agents. Okay, so desiring sedation, not talking about anesthesia really, just really talking about desiring sedation and how we're going to utilize this to give us moderate sedation, right? We're not doing anesthesia sedation, we're doing moderate sedation. So again, because of the rapid onset and the short duration, we love that, we love it. And we might give you a bolus until we get you under control, we get you sedated, and then we're going to start that continuous infusion at 5 to 10 mics per kg per minute, and then we're going to increase every 5 to 10 minutes, and max is 100. Now, in my practice, our max is typically 50. Above 50, everyone is nervous. Nobody really wants to go above 50 because we have a lot of concern about the lipid overload that can occur at a higher dose of propofol. And of course, adverse reactions that happen immediately are hypotension coupled with bradycardia. Remember, that's never expected. Whenever you have hypotension, you always expect tachycardia. Here with propofol, hypotension and bradycardia. So really important to look at that duo of dysfunction. But here's the thing that I think is really important, that historically, when we talk about propofol infusion syndrome, often been reported in the past in adults, even who are on recommended dose limits. So remember, max is 100, but typically we say up to 50 is a good dose limit. That's really a great way for us to look at how we're going to manage our patients. But propofol infusion syndrome, the PR stands for propofol infusion syndrome, has been reported in adults, even those adults who are within the recommended dosing of propofol. So really important when we're thinking about that. Okay, so propofol infusion syndrome, typically the trio of events that give us second thoughts on patients that we're administering propofol is unexplained metabolic acidosis, EKG changes, and then an evolution into acute kidney injury or rhabdomyolysis. Remember, rhabdomyolysis in itself is just the lysis of the cells, and that occurs because of the dysmetabolism, okay? So typically, we talked about this occurring in patients who are on propofol for longer than 24 hours at a higher dose, but recent reports say it can occur with lower doses. Now, let's be sure we appreciate propofol infusion syndrome is not common, or it is not commonly reported. We're not sure which. okay? Because we're talking about critically ill patients who have metabolic acidosis, who have EKG changes, who have AKI, that we may not be identifying in these patients that they have failure related to propofol. But a particular specific complication is that there's interference with the mobilization and the metabolism of oxygen. So that's what I mentioned before. Oxygen goes through a large variety of transport of its electrons to actually get it to its stable end. But what happens here is that we have a failure of that transport system that then produces a lot of reactive oxygen species. Now, you're not going to measure those, you're not going to draw those. You just want to appreciate that this dysmetabolism results in a high level of reactive oxygen species, which are very destructive, okay? So really, really, really important to also appreciate that an unexplained metabolic acidosis patient seems like you've restored his perfusion, things look pretty good. All of a sudden, he's got a base deficit and his lactate level is going up. What will always be important is to give the patient a trial of discontinuation of propofol. If I stop propofol and the metabolic acidosis has to be really in the early stages, but the metabolic acidosis clears with the discontinuation of propofol administration, I really feel good about that. I'll feel pretty clear that it was the propofol that was inducing this. And I think that's really important for us as bedside providers, because I love to chase metabolic acidosis, chase it with volume, chase it with inotrope, chase it with vasopressors. But also we need to consider, is it possible that we have caused it with our propofol? So I want to go back up here and I just want to remind you, unexplained metabolic acidosis, EKG changes, we're going to look at it, and rhabdomyolysis. But underneath rhabdomyolysis, what I'm going to tell you is something really straightforward. And that is an increasing CPK. Now, as we see an increase in CPK, what that means to us is we're lysing our muscles and flooding our serum with the internal contents of the muscles. So again, that trio, unexplained metabolic acidosis, EKG changes, and rhabdomyolysis as heralded by an increasing CK. Okay, so now we just take this nice look at a visual here that just reminds you about patients who have critical conditions. They have systemic inflammatory response syndrome, multi-organ dysfunction. We initiate propofol, we're giving them catecholamines, and this is now going to really interrupt metabolism at the cellular level. As metabolism at the cellular level becomes interrupted, what we're going to see is skeletal muscle lysis, we're going to see cardiac failure, and this is really straightforward, because what I want you to remember is this is a metabolic failure. It promotes significant and profound metabolic acidosis. We're going to start to see a dysrhythmia. We may see high lipids in the blood early on. The liver is going to be enlarged. We may see the evolution of rhabdo and AKI or acute renal failure. Most likely you're going to have hyperkalemia. The muscles are wasting potassium into the blood. You've got acute renal failure, so you're retaining potassium. And what actually is going to happen is, if this is unrecognized, even if it is recognized, if it's not prevented, let me say it that way, propofol infusion syndrome has about an 85% chance of mortality. And when we think about that, I'm sure it's appalling to all of us, because we're adding propofol because we believe that's giving you comfort. It's a very nice sedation capabilities. We're not trying to cause metabolic failure or initiate a big failure for our patients and promoting cardiovascular collapse. Okay, so why does this happen? I think I've already discussed it, but I'm going to say it again. I wanted to make it as simple as possible because I'm simple, because I want to explain it to you simply. I don't really need to use a lot of enzymatic words. I just want to make sure that you appreciate that there is an enzyme which breaks down the fatty acids. Propofol inhibits that enzyme, that's carnitine palmitoyl transferase, and that allows fatty acids to start to accumulate. Once that fatty acid starts to accumulate, it causes a failure of the respiratory chain. That's really the metabolism of oxygen. And because it causes a failure of the respiratory chain, at the end of that, we have reduced energy. That's the ATP. Now, because we are not actually able to oxidize the fatty acids because we've had a failure of the electron transport chain, and that you'll remember from nursing school, maybe with dread, the beta oxidation fatty acid chain. Okay, we've got a failure of that chain now, and now fatty acids are going to start to accumulate in various organs, like the liver, like the pancreas, and like the heart. Okay, and as that free fatty acid gets deposited, we're going to start to see cardiac arrhythmias. Now, the number one therapy at this moment is if I am recognizing cardiac dysrhythmias that I believe and that my team and I have discussed has promoted cardiac arrhythmogenicity, the number one thing you're going to want to do is give that patient carbohydrates. If you give them more carbohydrates, so you could give them D10, you would do a D5, whatever carbohydrates you can administer, that will offload some of those free fatty acids and restore more normal metabolic function. It's not a treatment, but it does give some protection. The other thing that's important is to appreciate that propofol blocks beta adrenergic receptor sites. So if I'm giving you dobutamine, you yourself are stimulating to increase your heart rate, increase your contractility, you will not be able to have an appropriate receptor uptake. So that's why you have that bradycardia plus hypotension, which is really unusual. The other thing that propofol can do with that free fatty acid component is it can actually bind calcium channels. If it binds calcium channels, the ionized calcium is no longer going to be available for effective myocardial contraction, which is why you start to see cardiomyopathy with propofol when you have a propofol infusion syndrome. It also, of course, now suppresses activity of sympathetic nerves. So that worsens the cardiac failure, and it also creates resistance to inotrope. So having said all these things, this is what I want you to hear from me. When you have a critically ill patient who is hypotensive, who is bradycardic, who has a reduction in his EF, always consider that it might be worsened, maybe not caused, but worsened by propofol infusion. And thinking about that, talking about that in the team, it is making my patient worse, but could propofol infusion be impacting my cardiac activity? I think that's something every patient deserves. Now, many of your patients will have tachycardia, good cardiac ejection, normalized blood pressure. Those aren't the ones I'm going to be worried about. I'm worried about the ones that are bradycardic and hypotensive. And again, one of the things I would think about is refractory metabolic acidosis, which we see all the time in our critical patients. And those patients will deserve an evaluation of their total CK. If CK is elevated and you're on propofol, this warrants a strong discussion at the bedside. Now let's think about who's at risk. Who's at risk for developing propofol-related infusion syndrome, right? People with head injuries, persons who are septic, those who have pancreatitis, trauma patients. So look at that. You've got a trauma patient who has pancreatitis and sepsis, and they're on propofol. They are going to be really likely to develop propofol infusion syndrome. One of the other things that's really important is this is more active and more common in a younger age group. What that means is for folks who work in a trauma ICU, that should be something they're thinking about frequently, about that context and that possibility when they're utilizing propofol. Okay, so prolonged propofol use means greater than 48 hours. Well, lots of our patients are on propofol for greater than 48 hours. Propofol dose greater than 4 milligrams per kilogram per hour. Some of our patients are on doses greater than that. Anybody who is receiving steroid therapy can actually be triggered into a propofol infusion syndrome. So that's also a really important concept when we're considering our patients to look at that risk when we're administering corticosteroids at the same time that they're receiving propofol. That again is a very significant highlighted dysmetabolism. Patients who have inborn errors of fatty acid metabolism, you know that from their history. You're not diagnosing that here for certain. And then, of course, inadequate delivery of nutrition with carbohydrates. So really, really important. So again, we kind of think about this at the bedside. I'm titrating up on your propofol. You've been on propofol for 72 hours. Now you appear to have pancreatitis, or you actually have a increased total CK and you have AKI, and now you have refractory metabolic acidosis. I'm not saying propofol is going to always be the cause. I'm saying we should always have intention when we're discussing what we're doing with our patients, and we should always bring to the forefront, could propofol be actually making the situation worse? Is it possible? And again, one of the most important things will be to discuss, should we take a look at total CK? That will be helpful to us. It's not 100% diagnostic, but it will definitely be helpful. So let's just take a quick look at the cardiac symptoms. Okay, with propofol, propofol-related infusion syndrome or propofol infusion syndrome, what we know is 88% of patients will present with cardiac dysfunction. 88% of patients present with cardiac dysfunction. And typically, what you're going to see is a widening of the QRS complex and, of course, bradycardia. Now, if you were interested in cardiology, if you were studying EKGs, something we talk about a lot, it doesn't happen much. We just had a patient 2 weeks ago who was diagnosed with Brugada syndrome, which is a genital chromosomal deficit that actually presents most particularly in the chest leads, V1 through V4, mostly highlighted V1 through V3, but some of the patients we'll look at will be V1 through V4. They have this ST segment elevation perspective. Frequently, these patients get STEMI activation. When a cardiologist looks at this, they'll actually say, no, this is not STEMI, this is Brugada syndrome. And you can see that you just you lose your whole J point. Really, you don't really have a good J point, and you have what we call a cove type ST segment elevation. Coved ST segment elevation typically doesn't actually tell us that you're having a STEMI. It's usually caused from another reason. But you'll see the P wave is quite broad and it's biphasic, which is very unusual. And you have kind of a longer PR, or what here would be called this is a PR, but could be PQ elongation. So T wave may be inverted. It may also be biphasic. So it's not always going to give us that much information. It's really this cove type ST segment elevation in a patient who has no chest discomfort, may not actually even have a cardiac history. Now, this occurs with propofol infusion syndrome, but it also looks like Brugada. And so a cardiologist who gets called on the case, if they don't know that you're giving a certain dose of propofol, they may actually say that's pure Brugada, but it isn't necessarily Brugada. It has a very similar like appearance, but it is propofol induced. So quite important. 88% of patients have cardiac dysfunction. If you're lucky, this is what you see. If you're unlucky, you've got VTAC, VFib, or asystole. Patients typically will progress from this Brugada perspective, and it may be very rapid with very little forewarning to asystole. 86% of patients have new onset metabolic acidosis. Okay, so, you had a trauma, you were intubated, you've had your surgery, you're at day 5, things were looking really good, and all of a sudden you're acidotic again, okay? But you're on propofol and you're on day 5. So we should be thinking, is it possible that this is propofol-related infusion syndrome? And again, when you're having that discussion, your team will say, oh, it's so rare, oh, it's so rare. Well, actually, it's not nearly as rare as we once thought. And there's also concern that the rareness of it is not that it doesn't occur, but that it's not reported because it's not recognized. Because it's kind of, okay, you're critically ill, you have refractory metabolic acidosis, you're hypotensive, you got some EKG changes, but I'm a trauma surgeon. I'm not really looking at your EKG, and I'm not that worried about your EKG. In fact, I didn't do a 12 lead, and maybe nobody at the bedside was noticing on the bedside monitor some of these changes. So I think that's really important. From that, we go to the next, which is the lysis of cardiac and skeletal muscle. And that's, of course, rhabdomyolysis. It's about 45%. You can see that you go down here, 37%. And amazingly, because really you would have thought hypertriglyceridemia would be much higher, it's actually much lower. And that's because those free fatty acids aren't necessarily what we're measuring when we look at hypertriglyceridemia. So again, very important that the person at the bedside has this in their mind when they're monitoring and managing their patients. Now, this is a propofol infusion syndrome EKG. Looks very much like Brugada because of this coved ST segment. You'll see it's primarily V1, V2, and V3, not really in V4, 5, and 6. But quite honestly, if I was looking at that EKG, my first look at that EKG, if you sent that to me or you texted it to me, I would say, oh, this looks like your patient's having a STEMI. But it's really bizarre. The changes are really bizarre. Also looks like the patient might have a right bundle branch block. The scenario doesn't quite fit a STEMI. But unless I know that the patient's been on propofol for 72 hours or that you just bolus them, it's fine. It's fine to bolus your patients with propofol. Just be aware what might happen. So really quickly, in Brugada syndrome, I do a whole talk on Brugada syndrome. I love to talk about it. It's so interesting. And unlike just about everything else with a 12-lead EKG, it's not completely burned into my head. All I can tell you is you almost always have a right bundle branch block pattern, right? So current goes towards the right. V1 is the right-sided lead, and then away from the right, and then back to the right. So a return to the right always indicates to us the possibility of a right bundle branch block. And you have ST segment elevation, V1, V2, usually up into V3. Very, very important. But again, looking at this, the appearance, which is this concave appearance of the ST, down sloping ST and the inverted T. This is unlike what you expect to see when it's STEMI. With STEMI, you tend to have a plateau and then a drop. And this does not have that. This has this down sloping ST segment. That doesn't mean it couldn't be a STEMI. It means that unless I'm a cardiologist, is going to be beyond my capability really to differentiate. And I need to call the cardiologist and say I have diagnostic uncertainty. I'm not going to activate a STEMI. I want the cardiologist to look at it. And I need to be prepared to share information, in particular, if the patient has metabolic deficit or if the patient is on propofol. Okay, this is a type 2. This is called the saddleback. And you can see got this little saddle looking method here. And then this patient actually goes down. This is the whole ST segment here. And then here's your patient's T wave. So typically the T wave is either upright or it's biphasic, whereas over here in type 1, your T wave is inverted. Nobody's asking you to remember all that. What I'm saying is, again, you're looking at your patient. He's been on propofol for 3 days. All of a sudden, you have something that looks like a right bundle branch block. You've got some ST segment elevation on your bedside monitor. By the way, your patient now needs a 12-lead EKG. And you need to gather your data. Does he have metabolic acidosis? What is this total CK? I don't have it. I need it. I'm calling Tyler. Tyler, can you order a total CK for me on this patient who's been on propofol for 3 days because I have concern about his EKG changes? Okay, so now we're going to look one more time at this patient, his 12-lead EKG, and this is a patient with true Brugada. Okay, true Brugada. Now that patient could also have propofol infusion syndrome. I'm going to have to differentiate that because propofol infusion syndrome presents like Brugada. And what's different from pure ST segment elevation is that you've got this very concave appearance. Typically, ST segment elevation does not present with concave. It presents really with what we call convex or plateau. So again, it's not 100% sure. You always need to do an EKG. And before you call for a STEMI, this is diagnostic uncertainty. And I would like to have my cardiologist take a look at it. Okay. All right. Now, just the last thing I want to just talk about is rhabdomyolysis. This is not my patient, a very nice publication in December 2021. 71-year-old lady found on the floor after she fell at home. She was uninjured and she'd been laying there for about 18 hours before her son arrived. Okay, well, she's found down. All that pressure on her surfaces that she couldn't move around is going to cause cellular lysis. And of course, that's what happened. She was unwell for about 3 days prior to this time. She had a cough and shortness of breath. She's got a medical history of comorbidity that really does put her at a risk. She's dehydrated, she's febrile, she's tachycardic. But the fact that she was found down and dehydrated tells you that she's not going to even pass go. She's going to go straight to rhabdomyolysis. She was on antibiotics. She got resuscitated, or they started antibiotics and they resuscitated her with LR, just a liter. Her high potassium was treated with 50% glucose, 10 units of rapid insulin. Her CK on admission to the emergency room was 200,000. Okay. And she had an acute kidney injury based on her creatinine and her BUN. Urine dipstick's positive for blood. Now, she does not have blood in her urine, but because of the heme, you will always test positive for blood when you are in rhabdomyolysis. Over the next 48 hours, they really were trying to resuscitate her. You know, you keep fluid 1 to 1 when you've got somebody who's got rhabdomyolysis. You alkalize their filtrate. You're not alkalizing their serum. You give sodium bicarb to alkalize the filtrate, because acidotic filtrate will destroy the tubules of the kidney. We also often will give mannitol. Mannitol promotes chelation of the heme. So that mannitol binds the free heme, which is very destructive to the tubules of the kidney. But she didn't get better with that. So she ended up going on renal replacement therapy. And you have to do that very quickly. One of the best methods and one of the best initiators, or why you should always consider CRT, is rhabdomyolysis. CRT should happen fast in rhabdomyolysis. You can't wait days trying to resuscitate. Maybe 12 hours, maybe 24. For me, 48 hours, way too long in a patient who's deteriorating like this. Okay, so now let's just take a quick look. On admission 24 hours later and 48 hours later prior to commencing renal replacement therapy. You can see she's inflamed. She has hyperinflammation. This is hemoglobin in grams per deciliter, not in the way we look at it because this is an English case. Platelet count is acceptable. PT is okay. APTT is okay. Her sodium is a little low, her potassium is high, her blood urea nitrogen is high, and I already converted her creatinine for you. I didn't convert everything. So her creatinine is 4.75 up to 5.88 and then up to 7.24. So this is all before starting renal replacement therapy. So you can see she is really an extraordinary mess here. She's a mess. And her total CK, 200K, 280K, 150K. So she's no longer lysing her muscles. That's why her CK is going down, because we've gotten her out of that situation. We're giving her volume, we're resuscitating her. However, the byproducts of that muscle lysis are still impacting her kidney. Okay, so really, really important when we're looking at this patient. You can see her bicarb actually was high, and I think she got some sodium bicarb when she came into the hospital. 24 hours later, I don't think she got any more bicarb, and 48 hours later, you're seeing that the bicarb is starting to drop. But we don't really have any other evidence or information here. We don't have an anion gap or any other way to look at whether or not she has metabolic acidosis. It doesn't appear so, which she was really lucky. Okay, so let's remember what rhabdo is. Rhabdo is breaking down. Rhabdo is striated muscle lysis breakdown. Striated muscle breakdown, rhabdomyolysis, skeletal muscle fibers. It is potentially life-threatening, of course, and very concerning to us. And again, if you don't have an index of suspicion in somebody who's on propofol, you might be looking for, well, they weren't found down. They weren't in the OR on the OR table for 18 hours without movement. How could this be? But what you want to remember is that muscle is highly consumptive of energy. And with propofol, you can alter that energy utilization, energy production. Typically, we're going to actually consider that somebody may have rhabdomyolysis in the index of suspicion if their total CK is greater than 10,000. Well, our patient was 200,000 when we first looked at her. And then we think about kind of this clinical perspective of myopathy, myositis, inflammation of the muscle, and muscle weakness, that rhabdomyolysis. Okay, so when we think about rhabdomyolysis, always really important to remember this is direct injury to the cell membrane. And what's really important here is that when you've been in crush, when you have been down, when you've been torn, when your muscle has been torn, when you've been burned, that's direct injury to the cellular membrane. But I want to remind you, another direct injury to the cellular membrane can occur with those free fatty acids that occur with administration of propofol. So one of the things that's really important here is that as the membrane becomes destroyed from outside the cell to inside the cell, sodium, water, chloride, and calcium will move into the cell. And from inside the cell to outside the cell, potassium, phosphates, lactic acid, organic acids, purines, myoglobin, creatinine kinase will all move outside of the cell because the membrane has been lost. And in addition to that, of course, you've got muscle cell hypoxia. You have depletion of ATP. And remember, we already talked about that free fatty acid, that propofol, actually can cause depletion of your ATP. Tyler, you're doing a very nice job of drawing on my slides. Thank you. That was lovely. Okay, so just remember what myoglobin is. It is the reddish pigment that makes your muscle look red. It's a heme pigment. Heme is destructive to the kidney. So, by the way, you will not have myoglobinuria unless you have rhabdomyolysis. It only occurs in the context of muscle lysis. Now, remember that rhabdomyolysis means striated muscle breakdown. The end effect of rhabdomyolysis is renal failure, but rhabdomyolysis is not renal failure. The problem is that heme is a really destructive pigment, and the glomerulus can filter it, but it has a very low threshold. If the presentation of heme goes higher, typically higher than 100 milligrams per deciliter, what you're going to start to see is that heme is going to spill over into the urine, making that urine red color. So 3 different enzymes, I always like to remind everybody, 3 different enzymes that we look at in CK. One is the BB, which is brain. 2 is the MB, which is muscle brain, that's cardiac. And then the third one, which is MM, which is muscle, that's CK3. Now, when we look at total CK, we're looking at all 3 of these. And when we're trying to look at, is this brain tissue or is this cardiac tissue, we're going to have to look at these, at the secondary isoenzymes, the BB, the MB. But here, all we're doing is looking at total CK and looking at the presentation of total CK. That's because even if it was BB or MB, it would never raise above the level of 10,000. And that's what's so incredibly important when we're talking about rhabdomyolysis. Okay. Oops. So sorry. This was really supposed to be animated, but that's okay. Underneath here, it says rhabdomyolysis. So with propofol infusion syndrome, I want to make sure you appreciate, we think about kidney dysfunction, we think about skeletal muscle dysfunction, but we've got a starving heart with severe cardiac dysfunction. And on top of that, you have all these other issues, right? You have free fluid in the interstitium in all of your compartments. So you have compartment syndrome, the direct effect of hypovolemia and the presentation of your heme or your myoglobin to the kidney promotes acute kidney injury, and hypovolemia makes that worse. You can have very significant coagulation deficits. That's usually pre-end of life. That's not an early sign where you're releasing thromboplastin and you're making small clots in small vessels. Hyperkalemia, no surprise, you lost your cellular membrane, you're releasing potassium into the extravascular compartment and into the intravascular compartment. Phosphate goes up because you're breaking down your muscle. Calcium goes up because you're breaking down your muscle. And then eventually calcium will move into the cell and get bound intracellularly and cause more cellular dysfunction. So one of the really important things is, if I think this is propofol infusion syndrome, despite the fact that your calcium looks low, I'm not going to give you calcium. That will actually make it much, much worse. So I really want to try to uncover what the problem is. And if we are so fortunate to have folks who say it might be propofol, the very best treatment is to stop the propofol. Stop the propofol and start cleaning the blood. So you're going to clean the blood with dialysis with CRRT, and in the worst case, your patient is probably going to need VV ECMO plus CRRT if you're able to give that. Probably won't live long enough to transport and wait for a bed somewhere other than your institution if they actually have propofol infusion syndrome. It's going to be rapid. So remember, you're going to watch for this if you suspect rhabdo. And the key here, myalgia, weakness, and dark urine, is really telling you if you believe you have rhabdo. Rhabdo is a later sign in propofol infusion syndrome. Remember what we looked at first: new onset, unexplained metabolic acidosis, EKG changes, and CK went up. Okay, so really, really important to us when we're thinking about this situation. Now we're going to combine that with signs and symptoms of rhabdomyolysis and how that's going to help us to evaluate our patient more effectively. Okay, so we're going to look for some early signs here, right? High potassium, high phosphorus, but remember, metabolic acidosis unexplained is going to be really important. With propofol infusion syndrome and rhabdomyolysis, cardiac arrhythmia is going to be early and important. And the first dysrhythm is bradycardia in the face of hypotension. And that bradycardia presenting with that wide-looking QRS with that concave ST segment can progress quite rapidly into asystole, and that will not be responsive. So that asystolic event will not be responsive. Some folks have tried pacing. Pacing has had kind of poor results in these patients, but you should always try it. Okay. So now we go back to that picture we looked at before and the clinical features of propofol infusion syndrome. Always consider it, if the patient is on propofol, of course, always consider it with unexplained metabolic acidosis, the EKG changes that we've talked about, in particular, looking like Brugada, occurring in V1 through V4, that concave ST segment and a wide PT, a wide QT, an abnormal looking P wave. Always consider that it's a possibility. And then, of course, the evolution of rhabdomyolysis. You should consider it in all patients who are receiving propofol, especially if they've been on propofol for greater than 48 hours, which I would say is 80% of your patients. It's also really important to consider that at some point you might need to add a secondary agent if you need sedation, particularly for bolusing. Because if you're already at a higher dose of propofol and then you're bolusing with propofol to control anxiety and to sedate your patients, it just may put them more and more at risk. That's why oftentimes if you talk to the pharmacist, they'll say, well, maintain propofol and bolus intermittently with Versed. So just be thinking about that in the way in which you're talking to your colleagues, the way that you're writing your orders. Let's really think about ways that we can try to limit what we believe to be relatively rare, but which is actually now discussed as not being as rare as it once was considered. So importantly, when we work these patients up for PRIS, unexplained metabolic acidosis, rhabdomyolysis unrelated to a trauma, AKI, cardiac dysrhythmias, and the lab results, which are not specific except elevated CK and myoglobinuria. These are specific. Okay, myoglobinuria is specific for rhabdo. Elevated CK is specific, in this case, for cell lysis. Patient can have elevated lactate because he's hypoperfused. That's not going to be specific. Patient has high potassium because he has metabolic acidosis. That's not specific. And they may or may not have high triglycerides. So what do we need to do? We need to avoid high propofol dosing. And we need to minimize the duration of infusion in patients who are at high risk. We looked at who those patients were. We want to avoid lipid overload by assessing all sources of fat calories. So, of course, if you were doing parenteral or enteral nutrition in these patients, you absolutely need a nutritionist on board. And that nutritionist has to look at the lipid administration of propofol because they're going to have to make different decisions about the balancing of nutritional support. We always need to assure that we have some adequate provision of carbohydrates in patients who are going to stay on propofol for any length of time. And it is recommended that you should be monitoring serum triglycerides in any patient who's been on propofol for greater than 48 hours. Okay, so monitor it frequently, especially if it's more than 48 hours. ABG, serum lactate, serum triglyceride, and creatinine kinase. Increasing levels of CK in the absence of other muscular pathologies should always trigger the suspicion of propofol infusion syndrome. And you should always stop the propofol until you know what is occurring. Now, by the way, I'm not saying take your patient cold turkey. I'm saying call your providers, call your mid-level, call your doc, have some discussion about the fact that the patient's CK is going up and there's not other muscular pathologies. They didn't get defibrillated. They weren't operated on. They didn't have a trauma. They weren't found down. And all of a sudden, CK is going up. That should always trigger suspicion propofol infusion syndrome. And you should stop propofol immediately. The other thing you need to do is be sure that you're using weight-based dosing so that we're not overdosing patients with propofol based on a standard protocol, but not looking as a weight-based dose. You're going to try hard to manage it, but my friends, actually managing propofol in infusion syndrome is really, really difficult. There are a couple things we can do. Remember, if the patient is quite bradycardic or close to asystole, you can try pacing, but it's had very limited success. Cardiogenic shock in patients who are on propofol, we're going to manage it with vasopressors, inotropes, and mechanical devices. We may have some degree of success. Single most important thing is get that free fatty acid out of the blood. So actually, it'd be much better if the patient was stable to do dialysis because you can move it quickly. But if you can't do that, CRT. And I'm not waiting. It's 10 o'clock in the morning. My patient has propofol infusion syndrome. I'm not waiting till you're done with rounds at dark 100 for a VASCAT. You've got to come now. We got to start now. We need to go forward. And it's going to be really important because we don't want to wait too much time to try to start to clear and purify that blood. We need to do it quickly. Okay. We can actually do some potassium management with calcium administration. My perspective is always chloride, as long as I have a central line. If I don't have a central line, gluconate is fine. I'm going to give some insulin, and typically I'm going to do it with dextrose. And also after I've done that, I'm actually going to have a bit more receptiveness to beta stimulation. We give beta stimulation because that precipitates and proliferates the transport of potassium into the cell, and that's why we do that. And of course, you can always do some potassium binding resin, which actually is very non-beneficial overall. I think it's always better to do calcium, insulin, dextrose, bicarbonate rather than any kind of binding resin. It just doesn't really help you very much. And of course, you can consider ECMO. If the patient is refractory, I can't get dialysis on, I can't move forward. They're refractory. They continue to have metabolic acidosis and cardiac dysrhythmias. I don't have a very long window of opportunity, but I'm going to have some discussion about ECMO. Okay, we're going to take a patient now. This is our 70-year-old female who's scheduled for an abdominal aortic aneurysm and reconstruction, undergone general anesthesia before without any problem at all. Height is 142, weight is 54 kgs, anesthesia is induced. She gets remifentanil and propofol at a target plasma concentration of 3 mics per mil. Operation time, though, extended significantly because she was bleeding a lot. So her operation went about 2.5 to 3 hours longer than it was originally scheduled. She was on propofol for a longer period of time and maybe at a little bit higher dose. On the second postoperative day, she had a prolonged bout of oliguria. She was breathing 45 times a minute on her SIMV. She had pretty significant respiratory she wasn't intubated here. She'd been extubated when she came out of the OR. She exceeded 45 times a minute with respiratory distress and on chest X-ray pulmonary edema. So elective reintubation was initiated. She got a 30 milligram bolus of propofol and sedation was maintained with propofol, after that bolus with propofol at a rate of 50 an hour, which is very common. The next day, she has a fever of 39.7 and she drops her blood pressure. So not at the moment you bolused her and not when you initiated the propofol, the next day, because it takes time for that free fatty acid to interfere with the cellular membrane. Platelets had dropped to 26,000. Creatinine, total CK, had gone up to 57,000. Now remember, anything greater than 10 is concerning. Now she gets a blood gas analysis during her propofol infusion. Her pH looks beautiful, 7.4. That's almost impossible with a PCO2 of 23. So she's breathing fast and deep. We already knew that, 45 times a minute. She still got intubated. She's still really overbreathing the vent on her SIMV. Her bicarb is 14, which means bicarb is down, her base is in deficit, not excess, deficit, and her metabolic acid is up. She has a wide anion gap. So bicarb down, base in deficit, anion gap is wide, acid is up, 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 and she has a mildly elevated lactate. So by the way, I'm not going to call this lactic acidosis. I actually am looking at this and saying this is a perfect case of propofol infusion syndrome. Perfect case of propofol infusion syndrome. Now let's just take a look at her. Here she is. Here's the OR, post-op day 1 through post-op day 13. Looking across here at her pH, her PaCO2, her PO2, her bicarb, base, anion gap, lactate, etc. What I want to focus on, because I don't want you to have to read everything, is what we just talked about on POD 6. Okay, so she actually had alkalosis prior to this time, but now her bicarb drops. Now she's in a base deficit, and now her anion gap, which had been okay on patient day 4 and 5, her anion gap is going up. Her lactate is elevated. Her CK is 46,000. Okay, it went from 5,000 on patient day 5 to 46,000 on patient day 6. Maxed at 57,000, and when she was at 57,000, her base is -9. Her bicarb is 14. Her pH is 7.4, almost impossible to have a pH of 7.4. She's breathing really fast and deep. She is fully compensated, but she's getting respiratory distress because she's just breathing so fast. You can also see that she was normothermic, then hyperthermic, and then she comes back to being normothermic. And then you want to look at her CK and her body temperature. Propofol was turned off on day 7. So look at her. To day 4, she was doing okay. And remember, on day 3, I believe it was day 3, either day 2 or day 3, she got that bolus of propofol, got put back on propofol. And as her propofol went up, right? We know it went up. She got it. She's on 50. It was stable, but she's accumulating the propofol. What you're actually seeing is her total CK actually maximizes here, and that's really on day 7. Her body temperature maximizes here. That's on about day 4. but she's still hyperthermic here. She has that little upshoot here, greater than 41. She's still around 40 degrees at on day 7, and now propofol is turned off. Okay, propofol goes off, and look what happens to her CK. It drops. Look what happens to her body temperature. It drops. So this was a case of an astounding team of nurses and providers and others who were looking at the patient and said, we think it might be the propofol. Let's turn the propofol off. They didn't want the patient to be anxious. They put the patient on Versed or another benzodiazepine, maybe Precedex plus Versed, but they turned off the propofol, turned it off, didn't really wean it off. They turned it off. And they gave something else before they turned it off so that the patient wouldn't be anxious. But look at how dramatic that event is of dropping the body temperature and dropping that total CK. That is, I feel, very important. So the key takeaways are here: prevent propofol infusion syndrome, monitor propofol, not just by the dial on the IV pump, but on the correlation to metabolic acidosis, cardiac dysrhythmia, and increasing total CK. Those are the big 3. Think about CRT. And by the way, if your patient has it, you got to pray, because most patients who initiate propofol infusion syndrome, unless we are right on top of them right in the very beginning, are not going to survive. Okay. So again, remember, new onset metabolic acidosis, cardiac dysfunction, rhabdo, highlighted by an increasing CK, renal failure, and most likely, but not all, high triglycerides. Remember the risk factors: severe head injury, sepsis, high exogenous or endogenous catecholamine glucocorticoid levels. That means everybody who's on high dose norepi and high dose epi, everybody who's getting Cyucortef at high doses, not 100 milligrams of Cyucortef, but higher doses, like a gram, like what they might do in the burn unit or what they might do in the neuro unit. Anybody with low carbohydrate to high lipid intake, and that's really the key. We're giving you all those lipids, but we're not giving you carbohydrates to balance that. And of course, anybody who's got inborn errors of fatty acid oxidation. Propofol infusion should not exceed 4 milligrams per kilogram an hour. And we should always be performing total CK and triglycerides in any patient who we believe is at risk. Thank you so very much. I so appreciate your sharing. I am going to end the video now, but I am going to come back to my team who's on the call in case there's any questions or discussion. Thank you so much for joining today's Tuesday Topics. Hope I'll see you again soon, hopefully tomorrow. Thank you so very much. Bye-bye.